Good evening, everyone. And thanks again to Andrew for his glowing recommendation. It's really nice to be here this evening. Thanks for dialing in. My name is Darshana Bhattacharjee. I'm a paediatric consultant, and I'm currently based in Cardiff in South Wales. And this evening's webinar is going to be about breathing problems in children under 5 and managing them outside of hospital. So we have a lot to cover today, but I hope that by the end of the session, you should be able to comfortably recognize and differentiate between acute and chronic breathing problems in preschool aged children, that is less than 5 years of age, presenting outside of hospital. You should feel confident instigating appropriate initial management and be able to refer to the new and updated NHS clinical support tools that we have available to us in assessing and managing acute respiratory conditions, and also being able to provide parent information resources as well and know where to look. And finally, I hope to give you some tips on when and how to refer to your paediatric specialist team. And a little disclaimer for the participants outside of the UK, everything that I'm referring to in terms of protocols for treatment and prescribing are relevant to the NHS. So please refer to your own national guidelines where relevant. So we're going to dive straight in to acute breathing problems first of all. So before I launch into the specific conditions, I want to give us just a very brief reminder of how the respiratory tract is divided. So generally, we divide the respiratory tract into upper and lower. The upper respiratory tract consists of the nasal cavity, the pharynx, and the larynx, and essentially stops just above the vocal cords or the voice box. And the lower respiratory tract consists of the trachea, the bronchi, the bronchioles, the large bronchus, and the lung tissue, the lung parenchyma. Now, whenever I assess an acutely unwell child, I use the ABCDE method, and I would encourage you to do the same. And again, if you're not familiar with this, please do go away and do some reading upon this. I'm sure most of you are. I have a whole separate talk on this, so I could spend ages on it. But essentially, what you want to do in cases of acute respiratory problem is, first of all, assess the patency of the airway, because if you have a partially obstructed or imminently obstructed airway, then you can't go any further really until you sort that out. And when it comes to breathing, you must assess the work of breathing in children with particular details to pay attention to. In reality, you're going to be assessing A and B simultaneously. But you just need to have the little system in your head. And bear in mind that you must treat each problem in each system before you move on to the next one, because obviously problems with the airway will kill you quicker before problems with breathing. And issues with A and B can affect circulation in children. You can have circulatory compromise. And again, this can knock into issues with consciousness level and disability. And obviously children can have problems with temperature as well and rashes. So again, just bear this systematic approach in mind. So when assessing the airway, in very simplest of terms, if you have a child in front of you that is crying and or vocalizing, this indicates that their airway is probably quite well patent. Obviously, if the child's consciousness level is depressed or they're making strange noises, then you might want to just quickly use the look, listen, and feel technique just to have a slightly better look. And again, this overlaps with the breathing side. So if you're unsure about the airway patency, look at the movement of the chest and abdominal wall in children. Is it symmetrical? Does the child have any recessions? And we'll go into this in a bit more detail in the next slide. Listen without a stethoscope if the child is having any abnormal sounding breathing or a noise like stridor, which is an upper airway noise, which we'll go into again in the next few slides. And obviously, if the child has a very depressed consciousness level, you may need to just get down a bit lower and feel any expire there to feel if they are actually breathing. And that's very basic. If we go into a little bit more detail assessing signs of respiratory distress in children, I like to take a head down approach with this, mainly because it helps me to remember everything in a good fashion. So first of all, a sign very specific to young children, and I mean infants less than 12 months of age, is head bobbing. So essentially, this is the head nodding forward and back as a result of underdeveloped accessory muscles. So babies with respiratory distress may well be nodding their heads up and down, which is called head bobbing. You might see another sign called nasal flare, where the nostrils are essentially flaring as a child is breathing. And you might note some blueness around the lips or central cyanosis, but this can be a very difficult sign to pick up clinically, and often we don't see cyanosis until the oxygen saturations are below about 85%, so it is a late sign. You might hear different noises. So again, I mentioned this noise stridor. So stridor is an inspiratory noise against a partially obstructed airway. And I'm going to do a little impression of stridor, so forgive me. It sounds like this. So it's really a kind of really distressing inspiratory noise for the child. And you'd usually see it alongside other signs of respiratory distress. Grunting, on the other hand, is an expiratory noise against a partially closed glottis. And this basically means that the child is trying to generate their own end expiratory pressure to keep the small airways in their lungs open in, for example, asthma. And it sounds a bit more like this. So a really forced sound. So if you notice the difference between the inspiratory and the expiratory noises, and again, the grunting in particular is very specific to children. Going further on down to the neck, you might see tracheal tug. Again, a sign that's a little difficult to pick up in very young babies who basically don't have much of a neck. So you might see it in an older child. And then heading down to the chest, I'm sure a lot of you will be really familiar with different types of recessions. So you can have sternal recession in the middle, or you can have intercostal or subcostal recession as a sign of respiratory distress. And you can also have abdominal breathing, where there's a seesaw pattern in the breathing when the abdomen rises while the chest falls. So again, another sign there. Don't forget to count the respiratory rate, and the respiratory rate does vary according to the age group of the child, and you can get a better idea of normal ranges by referring to Pew's charts, Pediatric Early Warning Score charts. Right, so our first condition, we are going to talk about croup, and which is essentially short for acute laryngotracheobronchitis. So essentially, croup is a swelling of the larynx and the subglottis, which, as you can see from the diagram on the left, consists of the airway. So it's an airway problem, so one that does need to be addressed quite promptly. So what causes croup? I'm sure a lot of you are seeing a lot of croup at this time of year. It's common cold viruses such as respiratory syncytial virus, RSV, parainfluenza, influenza. We don't often test for viruses for croup when the child is in hospital, but we do know that's what they're caused by. The typical age range is between 6 months and 6 years. So if you see a child with so-called croup outside of this age range, just think twice about what it might be. This is an illness that's usually mild and self-limiting, so it does resolve within a few days, and it tends to present with coryzal symptoms, so runny nose, sneezing, up to 48 hours beforehand, but sometimes the prodrome can be very quick. It can be about 12 hours. Typically, kids present with hoarseness of their voice, a barking cough, and this inspiratory stridor with difficulty breathing, and parents tend to report that it's worse at night. Now, an important differential to be aware of is a condition called epiglottitis, which is caused by Haemophilus influenza bacterial infection. This is now exceedingly rare, thankfully, because of good immunization. But if you have a child in front of you who is looking very toxic and febrile and drooling and not wanting to swallow their secretions, then you may want to suspect epiglottitis, which is a pediatric emergency. Another differential, which I haven't put there, again, will be led by the history, is aspiration of a foreign body, particularly in young toddlers. So again, think of that if there's a sudden onset of stridor and difficulty breathing. I want to show you a little video of what croup looks and sounds like. So please bear with me while I do some other screen sharing. So this little girl, we start by hearing her barking cough. And hopefully you all heard that. And I'm going to move on and play you her stridor. Let me just make sure. Okay, no, I don't need to do that. Excuse me. And this is her stridor. So you can hear her breathing in with this stridor. She's got some tracheal tug.
I think it's because you might have your headphones in, Darshana. I think it's not broadcasting through the system.
Oh, okay. I will unplug my headphones and I'll try again.
Sorry.
That's all right. Tell me, is that any better?
No, I don't seem to be able to hear it. Sorry.
Oh, okay. Sorry. Lovely, lovely technology. Let's try again. So I can't seem to share this sound on my screen, Andrew. Is that something that I'll need to do?
Um, it might be because your headphones are connected. Don't worry. I'll be able to find this video and share it on the chat.
Okay, sure. So essentially, it's a child with biphasic stridor that you'll be able to hear here. So apologies for that. It worked last time, so I do apologize. Right, let's get back to where we were. So when when assessing a child for croup, you do have a very handy Wesley croup score that you can access, and this essentially helps you to categorize whether the child has mild, moderate, or severe disease, and what degree of treatment you need to go for. So as you can see, up to a score of 3 is quite mild illness, between 4 and 6 is moderate, and then over 7 is severe. And that's essentially if you have stridor, severe work of breathing, and you're hypoxic with a decreased level of consciousness. So treatment-wise, if you have a child in front of you with stridor, we generally recommend not to examine the throat or distress the child unnecessarily because it can worsen the stridor. In mild illness, a single dose of oral dexamethasone at the standard dose that we have here is usually effective. If the child is febrile or in pain, antipyretics work, and giving good parental safety netting about when to come back to seek further help is also necessary. Essentially, if the child has ongoing stridor, they will need to be referred to secondary care rather than having multiple doses of Dex given at home, just because of the risk to the airway. So if you are referring to pediatrics in hospital, if the child hasn't already had it, give them a dose of dexamethasone before transfer. If they can't take oral medication, they might need nebulized budesonide, but I'm not sure if that will be available to a lot of you. If they are in severe distress, then an adrenaline nebulizer it works very effectively, but the effects wear off quite quickly as well. So the child does need to be transferred in an ambulance with a paramedic crew. So next we're going to talk about wheeze. Now this is quite a broad subject in itself. It can present in children less than 1, and we call it bronchiolitis. In the 1 to 5 year age group, we refer to it as viral induced wheeze. And over 5s, the presentation tends to fall in line with asthma. And for the purposes of today's talk, I won't be covering asthma because it is a huge subject in itself. And I'll be chatting more about bronchiolitis and viral induced wheeze. Just to have a brief definition of wheeze as an entity, what is it? It's essentially a whistling sound that occurs due to bronchospasm or narrowing of the bronchioles in the lungs. It tends to be more prominent during expiration, but it can be biphasic. And it's caused by infection, any viral or bacterial infection, inflammation, such as in asthma, allergy, or secretion, such as in bronchiolitis. We'll start with bronchiolitis. naturally, as this is usually diagnosed in infants under 12 months. There's a bit of a gray area at the 12 to 15 month age range, but this is where kind of clinical judgment and expertise comes in well handy. Bronchiolitis tends to peak between the ages of 3 and 6 months, and there are certain higher risk groups, such as premature infants, who may or may not have chronic lung disease, infants with a significant congenital heart disease, and those with neuromuscular disorders, such as spinal muscular atrophy. Again, I'm sure a lot of you are seeing bronchiolitis at this time of year, and I'm sure you know that it's commonly caused by RSV, respiratory syncytial virus, but it can also be caused by other common cold viruses, rhinovirus, parainfluenza, adenovirus, and human metapneumovirus, all of which can cause quite severe illness. Studies earlier this year have shown that the malignant strain of coronavirus rarely causes bronchiolitis actually in this age group. So that's something that we don't need to be as concerned about. And what we often see is that children, babies who present with bronchiolitis, they frequently catch an infection from a school-aged sibling. So always ask about who else is in the family. Presentation-wise, you have initial coryzal symptoms, sneezing, runny nose, runny eyes, followed by a chesty cough after about 24 to 48 hours, with usually increased work of breathing. And some children may have reduced feeding with or without vomiting as well. In very young infants, less than a month, they might have apneas and a pierced nose, which is obviously a red flag sign. And in unimmunized babies, you need to consider whooping cough as a differential. The natural history of bronchiolitis is that day 3 is usually the peak of the illness. That's when symptoms are usually the most severe, between day 3 and 5. And then children get better. The whole illness can last about 2 weeks, but the cough can last for up to a month. And it's important to inform the parents that if the child is otherwise feeding well and not very distressed with their breathing, then the cough is quite normal for up to a month. So when assessing a child with bronchiolitis, you want to really have a really good look at their work of breathing. Generally, a respiratory rate of greater than 60 in an infant is significant. And if you have the ability to measure oxygen saturations, see if their oxygen saturations are below 92%. And the typical signs of respiratory distress, which we covered earlier on in the diagram, will likely be there. So head bobbing, nasal flaring, they might be grunting. You might see tracheal tug, and obviously the various recessions. Assess their feeding and their hydration status. A general rule of thumb is that if a baby is taking less than half of their normal feed volumes, either through bottles or breastfeeds, then they will probably need hydration support, especially if they're vomiting after feeds as well. And if their frequency of wet nappies is reduced, then again, that's a sign that their hydration is suffering. We'd usually expect one nappy every 6 hours or so at the very least. Treatment is largely supportive. So in children with mild illness who have normal saturations, normal respiratory rate, but with some increased work of breathing, advising smaller and more frequent feeds, it usually does the trick, and close monitoring. And again, as I've mentioned, it's important to explain to the parents the natural history of the illness and the fact that around day 3, kids are likely to get a little bit worse before they get better. And there's a really nice resource for parent information called Healthier Together. And there you can actually send parent information virtual leaflets to their phones with their consent. So you don't need to shuffle around with lots of paper leaflets. We don't routinely treat bronchiolitis with antibiotics or salbutamol or steroids just because the pathophysiology is different. It tends to be viral, as I said, and certainly the wheeze does not respond to salbutamol or steroids. So I'd really steer clear of those unless you're in that funny gray area between kind of 12 and 15 months of age. And again, you'll need to use a kind of clinical acumen to decide there. Obviously, if your child has signs of respiratory compromise and really subpar feeding, they'll need to be referred to pediatrics for further support. This can be in the form of high flow oxygen or CPAP for their breathing, or nasogastric tube feeds or intravenous fluids for their feeding. So again, warn the parent or caregiver that that's probably what's going to happen if they do end up in hospital. And again, you can refer to NICE guidance as well, just to help you kind of remember these little bits for treatment. So next we'll move on to viral induced wheeze. So it's a slightly older age group. Very similar presentation in that children have a coryzal prodrome, so they have sneezing, runny nose, all the rest, which is then followed by cough, wheeze, and increased work of breathing after a day or two. Again, some children might be feeding less, they might be vomiting after coughing. And again, I was going to show you a little video just to demonstrate wheeze, but if the sound isn't working, I'll let Andrew share that video later on. So when assessing a child with wheeze, it's always important to determine the severity of their condition. Generally, if a child has good saturations in air and they have moderate increased work of breathing and moderate wheeze with good air entry, then they are safe to be treated outside of hospital. But if they have their parameters outside of the normal range and marked work of breathing, or they are really tiring, becoming cynos, then they'd fall into the severe or life-threatening category. So those children will certainly need to be urgently referred to the pediatric team. Regarding treatment, so if you have the ability to do so, always check the oxygen saturations and give oxygen if they need to keep their SATs above 92. In mild to moderate illness, you can manage children with bronchodilators via spacer, and that essentially means salbutamol up to 10 puffs every 4 hours can be given safely at home. And we use a spacer because a lot of the time children don't have very good inhaler technique. And the spacer just helps to disperse the salbutamol particles and just makes it a lot easier to deliver into the lungs. You can also give oral steroids in the form of prednisolone, depending on your local guidelines, the dose. And again, another inhaler you can use is ipratropium bromide if you have that available to you as well. Hydration is obviously key, so counsel the parents to make sure the children are drinking adequate fluids and are passing urine regularly. And again, we'd discourage routine use of antibiotics unless there's signs of a superadded bacterial infection, such as high fever or localized signs on the chest. And again, you can give really good parent information via the Healthier Together website. And there's also a wheeze, an inhaler plan there that parents can use to escalate treatment and to de-escalate treatment. And this is really useful because children who have an episode of viral induced wheeze, they tend to have recurrent episodes throughout the kind of preschool age. So if parents are confident on instigating treatment at home, that's greatly helpful for healthcare professionals as well. So the next acute condition is community-acquired pneumonia, which again, I'm sure a lot of you are very familiar with. It's infection of the lower respiratory tract and lung tissue, leading usually to consolidation, as is nicely demonstrated on this chest X-ray. Again, there are certain groups of children who are at higher risk of getting a pneumonia. So children who are significantly immunosuppressed, such as post-bone marrow transplant, or severe combined immunodeficiency, and children with cystic fibrosis, especially under 2 years. These two groups of children will definitely need isolation if they are referred and admitted to hospital. And then you have the kind of same groups of children that we've mentioned before. So kids who are born prematurely with or without chronic lung disease, children with congenital heart disease, kids with tracheostomies are also at risk, and those with neuromuscular disorders that don't have effective breathing patterns. So generally in children, pneumonia is caused by viruses in up to a third of kids, but this can be quite hard to distinguish clinically. And the common bacterial pathogens we find are strep pneumoniae in young children, Staph aureus, and your atypical mycoplasma. Now, there has recently been a resurgence in measles outbreaks, so always check the immunization status of children that you're seeing, especially the MMR. And if children are unimmunized, obviously it's a good thing to encourage them to get the immunization if you can. Presentation-wise for pneumonia usually presents with a high fever of 38.5. If you're dealing with a young infant, less than 3 months, a temperature of more than 38 is significant and should be addressed. Obviously, children have cough and difficulty in breathing, dyspnea, and some might even complain of pleuritic chest pain. More commonly, you have children that have referred pain to the abdomen, so they might complain of abdominal pain in the right or left upper quadrant with a lower lobe pneumonia. And some children may again vomit after coughing, and you might see sputum in the vomit, but you might not. Young children tend to swallow their sputum, so it's quite hard to get a sputum sample in these cases. So when assessing a child, again, the usual things, check their respiratory rate and adapt that according to the age of the child. Generally, an infant under 12 months, if their respiratory rate is greater than 70, that's significant. If they're older than over 50 years. And again, if you're able to check their oxygen saturations, do so. But hypoxia can present as agitation or a depressed level of consciousness in young children too. Obviously, when examining the chest, you'd want to percuss the chest and also listen for any localized signs. And if wheeze is also present, that could be a sign of atypical infection. Children might be lethargic, they might have circulatory compromise due to hydration, so bear that in mind. And obviously, if they show signs of severe illness with tachypnea, severe respiratory distress or cyanosis, then they'll need to be referred to pediatrics straight away. Treatment-wise, for mild to moderate disease where children don't have any severe features, the first-line treatment is still oral amoxicillin for 5 days, and you can get the doses from your formulary. In severe disease, again, likely to be in hospital rather than out of hospital, we would give high-dose co-amoxiclav. And if there's any suspicion of atypical infection, then a macrolide can be added to the amoxicillin, such as clarithromycin or erythromycin. Again, if there's signs of penicillin allergy, then a macrolide can be used instead as well. Antipyretics are always good for fever and pain. And obviously you want to encourage regular fluids or breastfeeds depending on the age of the child. Good safety netting yet again. Give parents advice on signs to look out for to bring the child back, such as increased effort of breathing, reduced fluid intake, including more vomiting or reduced responsiveness. And good practice is to review the child 48 hours later if the fever does not settle. And the reason for that is some children might be unlucky enough to develop an empyema on the back of a pneumonia. So if they have an ongoing fever, then it is worth just seeing them again and listening to their chest, maybe doing a chest x-ray. Wow, I've talked a lot. I'm just going to take a quick sip of water. All right, so the second part of, excuse me, this talk is about chronic breathing problems, of which I have one. I've got a little cough myself, so excuse me. So again, a quick recap. So there's a lot of reasons behind chronic breathing problems, but I'm going to keep it as simple as possible as I can today. So again, I've divided it up into upper and lower respiratory tract problems. Upper respiratory tract problems tend to present in the form of snoring with children with chronic breathing problems, and lower respiratory tract issues might be a chronic cough. So I'm just trying to keep things as easy as possible. So let's talk about snoring first of all. So snoring really is only problematic if it's persistent, if it's very loud, and if it's associated with periods of ineffective breathing. And ineffective breathing, excuse me, can take the form of choking, gasping, or just irregular breathing patterns during the night. So the key points to ask about in the history with snoring is, does it occur every night? Can a parent hear them from a different room? And is there any associated disordered breathing, such as choking or gasping, or a pause for more than 10 seconds? And interestingly enough, does the child complain of a headache the next day or feeling tired? Because if they're having signs of sleep disordered breathing, then this may well be impacting their school performance, their learning, and their behavior. So always important to ask if there are any changes in that. As you can see, there's quite a wide range of differentials for snoring, and I'm not going to go into every single one of these, but by far the most common cause of snoring is obstructive sleep apnea, or OSA, as a result of adenotonsillar hypertrophy, or allergic rhinitis. So if we talk about adenotonsillar hypertrophy first, as you can see on this lovely diagram, tonsillar enlargement can be quite obvious, but you do need to examine the throat with a tongue depressor, because just asking the child to open their mouth, they may not be able to do that wide enough. You may be able to see enlarged adenoids, but it's not always that easy. So definitely tonsillar enlargement is one to look out for. And then the management of obstructive sleep apnea with adenotonsillar hypertrophy is, you first want to document the tonsillar size as best as you can. I mean, again, it'll be medium, large kissing tonsils rather than actual measurement. If the child is overweight or obese, we do know that there is an association with OSA, so you will need to address the weight if that is the case. You might want to refer for a chest X-ray to rule out any lower respiratory tract pathology. And if there is evidence of tonsillar enlargement, there's likely to be adenoid enlargement. So consider intranasal steroids for a period if the child does have mild to moderate symptoms. When should you refer for OSA? So really, if there's signs of obstructed sleep disordered breathing that's been going on for a while, then a referral to the ENT team for sleep study and consideration of an adenotonsillectomy is usually the first port of call. But suspected severe sleep apnea might need urgent specialist assessment from, say, a specialist pediatric respiratory team, depending on how local they are to you. Now, tonsillitis obviously can fall into the acute breathing problems category as well. I was umming and ahhing where to put this, but I've decided it follows more naturally here. So tonsillitis is very common, tends to occur from the age of 3 years and above, because that's when the tonsils are fully formed. It's usually a clinical diagnosis using the fever pain score, and the fever pain score essentially stratifies the likelihood of it being a streptococcal infection. So what the fever pain score looks at is obviously fever over 38 during the previous 24 hours, purulence or pus on the tonsils, whether the patient attends rapidly within 3 days of onset because of symptoms, whether they have severely inflamed tonsils, and a lack of cough or coryza. But again, it's a little bit tricky because big tonsils can make a child cough. So again, it's using your kind of clinical judgment there. And helpfully, exudate or pus on the tonsil does not always mean a bacterial infection, which is why this fever pain score is quite valuable in kind of risk stratifying whether or not it is. Treatment, depending on what the etiology is. If it's viral, you obviously treat symptomatically with pain relief and with fluids and regular review. If the fever pain score for the child is 4 or 5, then there's a 65% likelihood of isolating streptococcus. So penicillin V would be the first line of treatment for 10 days. Now, antibiotics unfortunately don't prevent tonsillitis from recurring. And the criteria for a tonsillectomy now is essentially 7 or more episodes of tonsillitis in 12 months, which sounds like a heck of a lot, or more than 5 in each of the 2 preceding years, or the presence of any complications such as quinsy. So it is quite a high barrier to get to, and obviously it will cause problems for the child and the family, but that is the current guidelines that we have to go by, unfortunately. So moving on quickly to allergic rhinitis as a cause of snoring and chronic kind of breathing problems. So this is very common. About a fifth of the whole population tends to have some form of this. But the key question is to ask in the history of the child is whether their symptoms are seasonal, whether they have any other features of atopy, such as eczema, asthma, any other food allergies, and obviously asking about environmental exposures, and particularly parental smoking and the presence of pets, and consider dust mite as well. I mean, when examining the child, you use your usual ABC method, but looks especially for mouth breathing, children rubbing their noses, whether they have watery red eyes or a cough or a kind of tickly throat, which might signify a postnasal drip. If you do investigations, then doing a total white cell count with a differential to show a rise in eosinophils might be helpful, just to show the allergic component, or you might want to send off a specific serum, IgE, to various foods or pet dander. Skin prick testing tends to be done by specialist pediatric allergy clinics, so in that case, we'll need a referral. And treatment, unsurprisingly, is avoidance of the allergen in the first instance, if at all possible, and then the use of antihistamines. So cetirizine is safe in children, it's non-drowsy. Chlorpheniramine does cause drowsiness, so is a good one before bed. And if kids have any sign of nasal congestion, then intranasal steroids, again, usually quite effective to help in this situation. And really, pediatric referral is warranted if symptoms are difficult to control or if more skin prick testing and more investigations are needed. So finally, we've come to chronic cough. So we're going to spend the last few slides talking about chronic cough. Let's just have some definitions of different types of cough first. So a chronic cough, we would define as a non-resolving daily cough lasting longer than 4 to 8 weeks, so quite a long time. A recurrent cough is 2 or more cough episodes per year, and each episode lasts more than 14 days. A prolonged acute cough is a cough lasting at least 3 weeks, which is usually getting worse rather than better and may need early investigations. And an acute cough is a recent onset cough lasting less than 3 weeks. So kind of 3-week mark is really what you need to bear in mind in terms of when to start investigating a cough. But bear in mind that it is quite normal for preschool-age children to have between 6 and 10 respiratory infections per year without any underlying immune system issues or faltering of growth. So again, that's something just to counsel parents and caregivers about if they are concerned about that presentation in otherwise thriving children. Yeah, I know, it's crazy, isn't it? So key points in the history of a chronic cough is first to try and determine, is the cough productive? Does it sound wet or is it non-productive, that is dry? Does the cough have any trigger, such as exercise or after eating? So after eating might signify reflux, and after exercise might point towards asthma. Are there any associated symptoms with the cough, such as shortness of breath, any chest or abdominal pain, or obviously, more worryingly, hemoptysis, so blood in the sputum? Ask about relevant past medical or birth history, such as prematurity leading to intubations. We don't have to be premature to be intubated, but obviously a history of intubations, or chronic lung disease, which is associated with prematurity, and any other features of atopy. And ask if there's a family history of anything relevant, such as cystic fibrosis or atopy. And really, one of the most important questions to ask is whether there are any smokers at home, and to give smoking cessation advice as needed. Red flags in the history would include weight loss or poor growth, symptoms of malabsorption such as diarrhea, and recurrent severe ENT or chest infections that land children in hospital needing intravenous antibiotics, for example. And obviously apnea is a red flag sign, but again, that's more of an acute presentation so I'm not quite sure why I put it in there, so sorry about that. As you can see, there's a very wide range of differentials of chronic cough, including aspiration of foreign body, which is why the age of onset of the cough is very important. So a foreign body, certain types of foreign bodies, such as peanuts, can be aspirated and then remain in the large bronchus and lead to inflammatory changes. So that can lead to a chronic cough. So do ask about that history in the appropriate age group, so in young toddlers. And then I've highlighted, or sorry, underlined protracted bacterial bronchitis, and that's essentially a long-term chronic bacterial infection that can commonly present in children as well. So I'll give you a minute just to browse that table. Again, I'm afraid I won't have the time to go into every single cause. So initial investigations, if you're faced with a child with chronic cough, is to assess their growth, first of all. So plot their weight and their height on an age-appropriate growth chart. And if the child is close to 5 years of age and they are compliant, you might be able to get them to do a peak expiratory flow. And if this is less than 80% of their height, then think of a possible early diagnosis of asthma. A range of blood tests can be quite useful for looking at raised infection markers, for chronic anemia, again, eosinophils in an allergic situation, or looking at serology, for example, atypical mycoplasma. The chest X-ray is always helpful and always justified. And so you've done all these bits. When should you refer? So really, if you have a child showing signs of poor growth or malabsorption, like diarrhea, then they will probably need further investigation for things like cystic fibrosis, even if there's no family history. If the cough persists despite your treatment or interventions, that's certainly a good reason to refer them on. And with preschool wheezers, frequent exacerbations leading to hospital admissions may well warrant further treatment, such as montelukast or a steroid inhaler and monitoring of their symptoms as they get older. Parental anxiety, on the whole, shouldn't be a reason to refer if you have a child that is reassuring in their clinical picture, with an absence of obvious underlying pathology. The way to reassure parents in this tricky situation is to explain that a period of observation or watchful waiting is quite helpful, especially if you are waiting for any investigations to come back. We usually discourage over-the-counter cough medications because they don't really have any benefit. And obviously, if there's anyone smoking in the household, excuse me, even if parents do claim they go outside when they smoke or change their jackets, even particles on their clothing can aggravate children's chests. So really, giving good smoking cessation advice is always key. If you have referred the child and there is a long period of waiting, which unfortunately is happening at the moment, then really you can chase results of any investigations that you've ordered and update the referral as necessary. And depending on the clinical picture and the likely diagnosis, you can initiate treatment according to your NICE guidelines, BTS, British Thoracic Society, or your local guidelines. For example, if you have a child who's had a chronic cough, chronic dry cough with atopy, and you suspect it might be asthma, a trial of inhaled steroids is perfectly justifiable. Or if you have a child with a chronic wet cough, that could be protracted bacterial bronchitis, and a 2-week course of a broad spectrum antibiotic, such as amoxicillin, is also completely warranted. Obviously, keep the child and parents updated with what you're doing and the state of the referral if you can. And for my colleagues in primary care, you're always welcome to ask advice from your local pediatric team via telephone and email, and they'll be more than happy to provide that advice while you're waiting. So we've come to the end, and I've somehow managed to keep to time. I'm not sure how. I think it's because those videos didn't work. I do apologize. But in summary, we've covered the recognition and differentiation between acute and chronic breathing problems in preschool age children presenting to primary care. Hopefully you'll feel confident now in instigating appropriate initial management using a range of NHS clinical support tools and being able to use the Healthier Together platform to give good parent information. And the website for this is what0to18.nhs.uk. It's a beautiful website. It's really helpful, and you can send parent information right to their phones. And hopefully I've given you some tips on when to refer to secondary care. Like I said, contact your local paediatric team if in doubt. And I hope this is helpful. Thank you very much.